But the challenge is there are few people who are willing to lose their power. It's hard. We need to appreciate hard things are hard.
Hello and welcome to the Global Health Uprooted podcast. I'm Simone, and in this episode, I had the privilege of talking with Professor Yap Boum, based in Cameroon. He has 14 years of experience as the regional representative for Epicenter Africa, the research arm of MSF, also known as Doctors Without Borders, where he has led research projects on infectious diseases such as tuberculosis, malaria, and Ebola. Professor Yap Boum is also a co-founder of Kmerpad, a reusable sanitary pad nonprofit, and iDocta, a platform to connect patients with doctors and health services. With all this experience, Professor Yap Boum shared insightful commentary on the value of local research for homegrown solutions, looking at the example of rapid antigen testing for the SARS-CoV-2 virus and how the capacity for mass testing can play a role in future pandemic preparedness. An important part of promoting homegrown solutions is securing local funding and equitable international investment. He highlights the necessity of matching needs with support so that aid is tailored to contextual needs. We discuss the movement of decolonizing global health and how this is changing global health research and practices, as well as the possibility of tracking the progress of authorship and training. Professor Yap Boum also introduces the concept of the village, a platform to match students and researchers to facilitate collaboration. I am so grateful to Professor Yap Boum for sharing his valuable insights, and I hope you learn as much as I did. Welcome to the podcast. I'm so excited to have you here today for what I have no doubt will be a fascinating conversation for all our listeners. To start off, can you please introduce yourself and share a bit about your previous and current working experience?
Thanks for inviting me, Simone. It's really a pleasure for me to be part of the postcard to share a bit our experience and what we are doing. I'm Professor Yap Boum. I'm working in Cameroon currently. I used to be the Africa representative for Epicenter. Epicenter is the research arm of Doctors Without Borders, Médecins Sans Frontières. I've been working with Epicenter for the last 14 years. And now I'm moving to the Pasteur Institute, which is based in Bangui, in Central African Republic, as the executive director. But still, I will remain in the board of Doctors Without Borders, Western Central Africa, just to highlight that what I'm doing is still working in Africa, trying to find homegrown and innovative solutions to the health challenge that our population is facing.
Great, thank you so much. It's a pleasure to have you here. So in the beginning of the COVID-19 outbreak, PCR testing was used for diagnosis, but this was not feasible at a large scale and in low and middle income countries. Yourself and colleagues tested the performance of rapid antigen and antibody tests for diagnosing COVID-19 infection and exposure in Cameroon. Using this example, can you please explain why local research is so important for low and middle income countries?
Yes, truly, COVID-19 has been a great opportunity for us to strengthen our healthcare system. As you mentioned, the WHO and the world was recommending the PCR as a way to diagnose COVID, and we actually worked hard. At the beginning of the pandemic, we were having only one laboratory, the Pasteur Center in Yaoundé. That was the only one having the capacity to detect COVID, the SARS-CoV-2, using the PCR. And from one lab, we moved currently to 45 labs throughout the country. But in the meantime, we realized that even having those labs, we were not able to provide the result within a limited time. By the time you take the sample, it will take 2 days, 3 days, 1 week, even 2 weeks because of the high number of tests. So we could not afford it. So we decided to find our own solution. Remember, our goal is to find homegrown and innovative solutions to respond to our challenges. So we assess the test, as you mentioned, the antibody, the antigen, and we figure out that the antigen was the one that was working for us. We could provide the result within a limited amount of time. And then based on those results, though we were not the WHO standard because they were asking a higher performance, we were able to give back the result within the time. So that's when we put all those new resolutions to ensure that wherever in the country, we can actually use those rapid tests. So that is one example of how we decided to respond using our homegrown solution.
Thank you so much. That's really valuable insight. Another issue is vaccination. So vaccination is an important part of managing infectious diseases such as COVID-19. And while some countries in the global north were handing out third doses of the vaccine, there were many countries in Africa and other regions in the global south with limited access to vaccines. How can global and local actors be better prepared for future outbreaks to work towards vaccine equity with things like future pandemics, but also current issues that we have with Ebola and HIV?
Yes, the vaccine equity is quite an interesting challenge. In the beginning, we were not the first to receive those vaccines. But in the meantime, we had to find our own solution, which are including, as I mentioned, the use of mass testing. And along the way, we realized that based on our different study on prevalence and so on, that our people eventually were not dying as it was expected, despite the circulation of the virus. Therefore, the population also decided that the vaccine was not necessary for them. So in Cameroon, we have a very high vaccine hesitancy, around 60 to 65%. Which means in one hand, we are able to test our population. In the other hand, people no longer want the vaccine. So we have to adjust the strategy to respond to the pandemic. So in one way, you have the government implementing the measure, but in the other hand, you have the population who decide what is good for them. So it's a bit how the community is also contributing to the response in our city.
Thank you. No, that's very interesting and important that communities are involved as well. So you're known to be an advocate for research and innovation in Africa, as you've mentioned here as well. And you're involved in various projects such as iDocta and Kmerpad. Since you've been involved in such interesting organizations, would you mind telling us a bit more about iDocta and Kmerpad?
Yes, in Africa, it's really challenging to have specialists. If you want a cardiologist, for example, in Cameroon, I don't know the exact number of specialists, but there are some regions where you have 2 to 3 million of people, where you have maybe one specialist, one cardiologist. So how do those people, those population, we have access to those care? So we decided to start iDocta because I was working on DRC Congo. I was responding to an Ebola outbreak, and my mom was sick. She was in Cameroon, and she was sick. And she went to the hospital. She spent 2 days. She went back home, but she was not feeling okay. And I was too far to come back and take care of her. So I tried to find some people to come and take care of her at home. It was not possible. So when I went back, I have to stop my intervention there to find ways to take care of my mom from home, because she didn't want to go back to the hospital. So I had to bring doctor, nurse, physiotherapist, and so on. And after 1 week, she was really fine because she did not really need to be in the hospital, but she needed the care. So we said there are quite a number of people who need that. And at some point, there was some GP generalists who were taking care of them, who were having some few questions. I said, okay, why don't you send a question to some specialists I know who are in France and different places? So creating that network around my mom, people coming to take care of from her at home, but also people who can give advice from far. I said, why don't you create the platform, which is called iDocta? iDocta, you have doctors, you have nurses, and you use telemedicine so that we provide the care. So we are on our way to partner with Kenya Health, that is based in South Africa, so that we can expand in all the Francophone zone. The second thing is Kmerpad. You know, when girls have the menstruation and they have no protection, Simon, you are a girl, you can imagine how this can be. We call it a psychological violence. When you cannot afford sanitary pads to go to school, or when you have an accident, when you are at school and then you have all the people around mockery. This is psychological violence. And we decided to address that issue by providing one, menstrual education to girls, but also to boys at school. Both need to be educated. 2, to provide reusable sanitary pads so that girls can comfortably go to school, women can comfortably go to their work. We started 8 years ago, we were having 2 or 3 seamstresses. Now we have around 40 of them. We work in Cameroon, we work in Niger, we work in DRC, in many countries. But we still need to have more and more people to support this initiative. And if you have some students who are willing to get involved in the challenge of menstrual health, menstrual hygiene, then we are looking forward to have them come in and support Kmerpad.
Oh, fantastic. We can definitely share information about those organizations. I think they are such great examples of how valuable homegrown solutions are. And there is so much potential for innovation, but a lack of sustainable funding opportunities in Africa. From your experience in these organizations, why do you think homegrown solutions are valuable, and how can funding be secured to scale up these innovative ideas?
So I was highlighting that as we talk about local solution, we must also talk about local funding. But we cannot rely on funding coming from the West if we want to solve our own problem. It has to come, we need to have indigenous funding. And Africa has never had as many billionaires as we do have now. So it's critical for us to look for our own money so that we can do our own research to find our own innovation that will solve our problem. This is where we are going to include philanthropies, corporate working in Africa, so that we have our own fund and we can support our own local researchers and institutions, of course, in partnership and collaboration, but with us leading our research and innovation.
I think that's really important. And as you mentioned, not having as many billionaires in Africa as you do right now is definitely worth tapping into that local wealth.
While saying that, I just want to add one point. While saying that, we are also saying that when we work with international partners, I'm taking the example of NIH, which is the US funding and research agency. When the NIH fund a research organization based in the US, they will provide 30 to 50% of indirect cost. Though that money will support those institutions to grow and to be able to build the capacity. So when they are supporting a non-US based institution, an African based institution, for example, they will not give more than 8% of indirect cost. So there is no equity. If those countries, those organizations want to support research, it needs to be in the very same way so that the investment in research remain the same, whether they are in the West or in the North. So to summarize myself, in one hand, we need to have indigenous funding coming from Africa, but in the other hand, we also need to have equity when the international organization investing money for research, either in the global North or in the global South.
I think that's really important to highlight. Thank you. And do you find as well that there are some issues with international funding setting the agenda as well on what gets funded according to what they think is important compared to what the local needs are?
Yes, we are currently organizing an international forum on the response to public health emergency. And yesterday we were having an interesting symposium on advocacy. And then we are having people from the WHO, people from Doctors Without Borders, people from Uganda, from different parts. And what came out from that is different funders, different organizations, they have their own mandate. They have their own agenda, which fit with their money. So if someone comes to your place and say, I want to work on malaria because that's why my people are given you money, and then they come to us where malaria might not be an issue in that specific district or region, but we have another issue, let me say with borrowing ulcer or something else, they won't give you that money. So they will impose you to work on something that might not be your main issue. And that's a big challenge. A huge challenge, because then we don't have the agenda for research, but also for the public health response. So it's critical that we have an international understanding going toward equity. If you want to help someone, the best way is to ask that person, what can I do for you? That's from the people coming from the West. But it's also critical in our side to have our plan on what we need, what we want to do, and just ask people, partners and vendors to stick to that agenda. If we don't do that, everyone at some point will be frustrated. Sometimes you will have some project that will match with both, but sometimes also you have project that will not match. You spend a lot of money in some initiative that will have zero feedback. It's critical to match the need and the support. That's the only way to provide true aid. If you come to give to someone something that the person doesn't need, then you are not helping that person. And that's a waste of resource, waste of energy, and waste of time.
Yes, I agree with you completely. And I think that's been a huge problem in the past with the mismatch between what is really needed and what researchers from the West come in and do. How close do you think are we to achieving this kind of equity in research, or is there still quite a long way to go?
I think there's a long way to go, but the COVID is an opportunity to move faster. There is also an important movement of decolonizing global health. You will find a lot of papers, articles coming from different parts of the world saying that we need to ensure that the research being done is addressing the local challenge. So I think we are moving in the good direction. We just need some acceleration and some catalyzer before we realize we will have changed the face of global health.
I hope that's where we go. Yeah, you mentioned the movement towards decolonizing global health, and perhaps to summarize, why do you think that this movement is important for achieving health equity?
Yes, it is influential because you have different people from different parts of the world who are trying to address the same issue. And when we put our brain and our will all together, we address all those issues. But the challenge is there are few people who are willing to lose their power. It's hard. We need to appreciate hard things are hard. If someone is spending his money for a project and he goes to publication and you're asking that person not to be the first author, of course it will be difficult. So it's hard, but with the high number of people getting involved, getting engaged, we'll get there. We'll get there.
You mentioned authorship, and I think equity in authorship and in publications and things is also very topical. Do you have some thoughts on that and how to move forward with that in line with decolonizing global health?
Yes, definitely. I think that the best way to address a challenge is to track the evolution. We did an article, I think 2 or 3 years ago. We did a review of all the articles published on Ebola, on malaria, and some neglected tropical disease, looking at where the African were positioned, first or last author, and we realized that around 30% of the people of African researcher was just first or last. All the other was stuck in the middle, and we published that article. So we start thinking that we need to do like every 5 years, or every 3 or 5 years, and to see how it goes. That's one thing. And we also need to see how the training program are increasing, because we just don't want to have people taking position without having the actual knowledge. And if you want to address that, we need to build capacity. So if you track the number of people trained, you track the number of articles where you have African well positioned, then you will see the actual impact. And that needs to be done. And then we can sit down at a conference and see, okay, how have we progressed? And if we have not, then we should figure out why not. And also, if we have progressed in the good direction, how to catalyze, how to accelerate the process.
I think that's a really good point of monitoring progress and keeping track of that. As far as I know, there's not really people designated to a position to keep track of movement in this direction. Do you know of any organizations or people that are trying to keep track of progress?
There is no organization that has that mandate, but researchers like me, like many groups, are actually looking at it. So maybe that's something that we should really put upon ourselves to keep on doing that in a regular basis.
Yeah, I think that it's so important that there are researchers like you who are driving that, and hopefully it has a ripple effect and moves on to other researchers and to students as well who are upcoming researchers. Do you have any advice for students studying global health or public health or infectious diseases, epidemiology, or anything that will be working in this kind of field on how they can optimize research practices to be in line with decolonizing global health?
I think the first thing for students engaging on global health and want to decolonize, the first thing is to start with the end in mind. They want to get engaged, they want to support, they want to learn something different from where they are. So they need to find people who can tell them what are their problems and figure out the need that they have. So that they come not an idea of we are going to implement something. No, we are going to learn. We are going to ask those people, what is that we can do for them and with them? That's the only way we will ensure that they will spend energy, the time on something that will make sense for the population where they'll be working. We are about to launch a platform which we are calling the village. In Africa, we say we need a village to grow a child, in the sense that the child belongs to the parent, the child belongs to the family, the child belongs to the community, and everyone is playing a role on growing that child. And now we are thinking about research, about scientists, about people involved in global health. You cannot do your research on your own. You are asking about a student in Sweden. If you, as a student, want to go and work in Africa, what do you do? How do you find the people you can work with? How do you find the faculty, the mentors in Africa? So we are creating that platform that we call the village, so that every student, every faculty, every university, every sponsor can create its own profile, a bit like what you do on LinkedIn, but also a bit like what you do on Tinder when you want to start a relationship. So we use artificial intelligence to match, can match with another student, can match with a university, can be matched with a mentor, and that will be able to create some relationship, some project based on the interest, based on the profile. So there will be no more borders. You won't need to know someone in Africa specifically to find a place where you can vent your research. You will not need to know someone specifically on Sweden if you are based in Uganda or in Cameroon to find a mentor to help you, to support you on your research, on your scientific writing. So the aim of the village is really to remove all those barriers so that we have one global health research village. And all of you will find your place in the village to involve and to decolonize global health, one, but also to learn, because all the students, all the researchers have to learn on how to find those solutions that will make sense for our population and our community. Because at the end of the day, we are all interdependent. So if one is bad, the other is bad.
Wow, that sounds amazing and much more exciting to me than Tinder. Yeah, that's such an amazing platform and definitely something that I can see making a big difference in facilitating connection and meaningful learning from each other. Great. This has been such an insightful conversation, Professor Yap Boum. Thank you so much for sharing your experiences and providing inspiration for me and for all our listeners. Thank you.
Thank you, Simone, and thanks for all of you who are learning how to work on decolonizing global health. And we look forward to having coming and learn in our continent, and so that we can work all together to find those homegrown and innovative solutions. Thank you.